Hello, incredible nurses in the making. Welcome back to Stancoast NCLEX, where nursing mastery becomes a daily habit. Here, we upload 2 to 3 advanced NCLEX videos every single day, filled with clear explanations, real-world scenarios, and Stancoast pearls that make learning practical, powerful, and unforgettable. In today's high-yield lesson, we are focusing on one of the most vital and skill-based topics in nursing: nursing care of clients with tracheostomies. This session will guide you through everything you need to know, from understanding the purpose and types of tracheostomy tubes to performing sterile suctioning, ensuring airway patency, and providing meticulous site care. We will also cover critical safety measures such as emergency tracheostomy management, prevention of accidental decannulation, and patient communication techniques that uphold both dignity and safety. So grab your notes and stay with us till the end, because every second in this video strengthens your confidence and clinical competence. And remember, at Stancoast NCLEX, we are not just preparing you to pass the exam. We are preparing you to save lives with skill and compassion.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us smoothly transition into this high-priority airway management scenario. A nurse is caring for a client with a tracheostomy who is receiving humidified oxygen therapy. During routine assessment, the nurse notes that the client's respiratory rate is 24 breaths per minute. Oxygen saturation is 92% and pulse rate is 98 beats per minute. The client appears restless and is making audible gurgling sounds through the tracheostomy tube. Now, the critical question arises: which assessment finding provides the clearest indication that the nurse should perform tracheal suctioning immediately? Here are the options to consider. Option 1, respirations are low. Option 2, pulse rate is slow. Option 3, breath sounds are wet and gurgling. Option 4, blood pressure is elevated. Correct. Answer: Option 3, breath sounds are wet and gurgling. Now let us explore the expanded and advanced rationale behind this life-saving nursing decision. When caring for a client with a tracheostomy, the nurse's foremost goal is to maintain a patent airway. Wet or gurgling breath sounds are the most reliable and immediate indication that secretions are obstructing the tracheostomy tube. These sounds result from mucus partially blocking the airway, causing turbulent airflow during both inspiration and expiration. Because many tracheostomy clients have a weak or absent cough reflex, they depend entirely on suctioning to clear secretions and maintain gas exchange. If this mucus is not removed promptly, it can lead to hypoxia, increased work of breathing, and eventually respiratory distress. Thus, audible wet breath sounds are an urgent red flag signaling that immediate suctioning is required to restore airway patency and oxygenation. Furthermore, tracheal suctioning performed with sterile technique not only removes mucus plugs, but also prevents atelectasis and supports effective alveolar ventilation. The nurse should remain vigilant for accompanying signs of secretion buildup such as restlessness, tachycardia, cyanosis, or declining oxygen saturation. By recognizing these cues early and responding promptly, the nurse prevents serious complications like hypoxia, infection, and mucosal trauma. safeguarding both airway integrity and patient stability. Let us now transition to understanding why the other options do not indicate the need for suctioning. Option 1, respirations are low, is incorrect, because a decreased respiratory rate is not a typical sign of secretion accumulation. Instead, low respirations usually occur due to oversedation, neurologic depression, or severe hypoventilation. Suctioning decisions should rely on clinical cues such as breath sounds and oxygen saturation changes, not the respiratory rate alone. Moving on, option 2, pulse rate is slow, is also incorrect because bradycardia is not an early sign of airway obstruction. During hypoxia or secretion buildup, the body's initial response is usually tachycardia and restlessness due to sympathetic stimulation. A slow pulse tends to occur later, often as a vagal response or a sign of worsening hypoxia, not as a primary indicator for suctioning. Lastly, option 4, blood pressure is elevated, is incorrect because hypertension may arise from stress, anxiety, or pain, but it does not specifically correlate with secretion retention. It lacks a direct connection to airway obstruction, unlike wet and gurgling breath sounds, which clearly reflect compromised airway clearance. Now transitioning to a Stancoast clinical insight that captures the essence of this scenario. Every gurgle through a tracheostomy is the lungs' silent cry for help. The nurse's swift recognition and timely suctioning response transform a potential airway emergency into restored breathing and stability. Now moving ahead to a Stancoast high-yield NCLEX takeaway that reinforces this concept. Always assess for audible gurgling, visible secretions, or falling oxygen saturation as the top cues for suctioning need. Preoxygenate the client before suctioning and limit each suction pass to 10 seconds or less to prevent hypoxia. Remain alert for signs of vagal stimulation, such as bradycardia or hypotension, and stop immediately if these occur. Consistent assessment, sterile technique, and timely intervention are the cornerstones of safe and effective tracheostomy care. Let us now move into this high-priority airway management question that highlights a fundamental aspect of tracheostomy care. A nurse is preparing to suction a client who has a tracheostomy tube in place. The critical question to consider is, which nursing action must the nurse perform first to ensure client safety and maintain adequate oxygenation during the procedure? The options are as follows. Option 1, preoxygenate the client. Option 2, moisten the catheter with sterile saline. Option 3, clean around the tracheostomy stoma. And option 4, remove the inner cannula. The correct answer is option 1, preoxygenate the client. Now, let us understand the reasoning behind this essential nursing intervention. Before suctioning a client with a tracheostomy tube, preoxygenation is the most vital and life-preserving action. Suctioning temporarily disrupts the flow of oxygen and removes not only secretions but also residual oxygen from the airway. This sudden oxygen depletion can quickly result in hypoxia and bradycardia, especially in clients with impaired respiratory function. To prevent such complications, the nurse should provide 100% oxygen for 30 to 60 seconds before suctioning. This crucial step builds an oxygen reserve that supports tissue perfusion during the suctioning process and helps maintain stable oxygen saturation levels. From a physiological standpoint, tracheostomy patients lack the natural humidification and filtration that occur in the upper airway. As a result, their secretions become thicker, and frequent suctioning may be necessary. Each suction pass can stimulate the vagus nerve, potentially leading to bradycardia, hypertension, or even cardiac arrest if oxygen levels drop too low. Therefore, preoxygenation is a protective step, that prevents these adverse reactions and ensures safety throughout the procedure. Suctioning should always be performed using sterile technique, with each pass limited to 10 seconds or less and followed by a 30-second rest period with supplemental oxygen. This practice helps prevent mucosal injury, supports recovery, and maintains adequate oxygenation. Moving forward, let us analyze why the other options are incorrect. Option 2. Moisten the catheter with sterile saline. Although some nurses may test suction equipment by aspirating sterile saline to confirm patency, routine catheter moistening before suctioning is no longer recommended. This outdated practice increases infection risk, may dislodge bacteria into the lower airway, and can provoke unnecessary coughing or bronchospasm. Evidence-based protocols emphasize preoxygenation as the true first step for client safety. Continuing on, option 3, clean around the tracheostomy stoma. While cleaning the stoma is indeed important for infection prevention and skin protection, it is not the immediate priority before suctioning. Airway obstruction caused by secretions poses a far greater and more immediate threat to life than stoma hygiene. Therefore, the airway must always be cleared first, and stoma care can be performed afterward once oxygenation is stabilized. Finally, option 4. Remove the inner cannula. This should only be done if the inner cannula is visibly blocked or during scheduled tracheostomy care. It should not be removed before suctioning, as doing so can interrupt airflow or introduce contamination. Suctioning is performed through the inner cannula to effectively clear secretions and restore airway patency. Now, before we conclude, let us connect this learning to Stan Coast clinical insight. Before every suctioning attempt, remember that each second of preparation determines whether your client remains safe or becomes hypoxic. A few deep breaths of oxygen can mean the difference between calm stability and a medical emergency. Preoxygenation transforms a risky procedure into a controlled, life-sustaining intervention. And to reinforce your NCLEX mastery, let us highlight the key exam takeaway. Stan Coast, high yield. NCLEX Pearl. Always preoxygenate with 100% oxygen for 30 to 60 seconds before suctioning. Limit suction time to 10 seconds or less per pass, and carefully observe for signs of bradycardia or desaturation caused by vagal stimulation. Maintain sterile technique and proper suction pressure, typically between 80 and 120 millimeters of mercury. Allow rest intervals between suction attempts to restore oxygen levels and prevent complications. Stepping confidently into our next advanced level NCLEX-style question, let us explore a vital scenario focusing on respiratory monitoring and client safety during suctioning. A nurse is preparing to suction a mechanically ventilated client with a tracheostomy. Before beginning the procedure, the nurse attaches a pulse oximeter to the client's finger to continuously monitor oxygen saturation. The question asks, which nursing actions are appropriate at this time? Select all that apply. The options are as follows. Option 1. Remove the client's fingernail polish or artificial nails. Option 2. Position the sensors so that the light emitter and detector are directly opposite each other on the client's finger. Option 3. Connect the pulse oximeter cable to the monitor and verify waveform accuracy. Option 4. Set the oxygen saturation alarms between 95% and 100%. Option 5. Notify the healthcare provider each time an alarm sounds. Option 6. Relocate the spring-loaded probe periodically to a new site. The correct answers are Option 1, Option 2, Option 3, and Option 6. To understand this in depth, let us move into the expanded rationale. Attaching a pulse oximeter before suctioning ensures continuous evaluation of the client's oxygenation during this high-risk procedure. Pulse oximetry operates by transmitting red and infrared light through a pulsating vascular bed and detecting light absorption by oxygenated and deoxygenated hemoglobin. Any barrier between the light emitter and detector, such as nail polish, artificial nails, or dirt, may cause inaccurate readings. Therefore, removing nail polish or acrylic nails, as stated in option 1, allows unobstructed passage of light for reliable SpO2 monitoring. Continuing with option 2, correct sensor alignment plays a major role in obtaining accurate results. The light-emitting diode, LED, and photodetector must be aligned directly opposite each other on a well-perfused site such as the fingertip or earlobe. Misalignment or peripheral vasoconstriction can cause false readings or erratic alarms, making proper placement crucial. Progressing to option 3, before initiating monitoring, the nurse should connect the pulse oximeter cable to the monitor and confirm the presence of a clear, stable waveform. A consistent pulse signal verifies accurate detection of arterial pulsations rather than venous flow, ensuring dependable readings during suctioning. Shifting focus to option 6, the spring-loaded or clip-on sensor should be relocated periodically to prevent pressure injury, impaired perfusion, or skin breakdown. This is particularly important for clients on prolonged oxygen monitoring or those with fragile skin integrity. Now, let us clarify why option 4 is incorrect. Setting the SpO2 alarm between 95 and 100% is not recommended because it can lead to excessive false alarms. Instead, the lower alarm limit should be set between 90 and 94% to provide early warning of hypoxemia without causing unnecessary alerts. When oxygen saturation drops below 90%, it correlates with a partial pressure of oxygen around 60 millimeters of mercury, signaling the need for urgent nursing intervention. Lastly, option 5 should also be ruled out because notifying the healthcare provider each time an alarm sounds is not practical or necessary. The nurse must first assess the client, verify probe position and signal quality, identify motion artifacts, and correct oxygenation issues before escalation. Only if the client's oxygen levels remain compromised after interventions should the provider be contacted. Transitioning now to the Stan Coast Clinical Insight. Pulse oximetry is only as reliable as its setup. A well-aligned, clean, and periodically rotated sensor transforms a flashing red light into a life-saving monitor of tissue oxygenation. And now for the Stan Coast High-Yield NCLEX Pearl. Always remove nail polish or artificial nails before applying a pulse oximeter. Reposition the probe every 2 to 4 hours to prevent pressure necrosis. Set alarms to alert for oxygen saturation below 90 to 94%, not at 100%. Always assess the client first when an alarm sounds, rather than silencing the device or calling the provider immediately. Remember, nail polish, ambient light, motion, or poor perfusion are the most frequent causes of inaccurate SpO2 readings, so always verify these before taking further action. Moving forward into another critical airway management concept, let us focus on a high-level NCLEX-style question that emphasizes both precision and patient safety during suctioning. When a client with a tracheostomy requires suctioning, the nurse's primary goal is to maintain oxygenation and airway clearance without causing tissue trauma. The question asks, at which point should the nurse occlude the suction control vent on the catheter to safely and effectively remove secretions? Here are the options to consider. Option 1. Before inserting the catheter into the tracheostomy tube. Option 2. As soon as the catheter passes through the inner cannula. Option 3. While gradually withdrawing the catheter from the airway. Option 4. Whenever the client initiates a cough reflex. The correct answer is Option 3. While gradually withdrawing the catheter from the airway. To explore this in depth, suctioning a tracheostomy is an invasive procedure that briefly interrupts oxygen flow and can lead to hypoxemia if performed improperly. The suction control vent, also known as the thumb port, controls the negative pressure within the catheter. The nurse should never occlude the vent during insertion because doing so applies suction while advancing, stripping oxygen from the airway and damaging the tracheal mucosa. This mistake increases the risk of vagal stimulation, which can trigger bradycardia or even cardiac arrest. Once the catheter reaches the pre-measured depth or resistance point, suction should be applied only while withdrawing. This technique helps remove secretions evenly while minimizing mucosal injury and oxygen loss. Gentle rotation during withdrawal ensures complete secretion clearance from all tracheal surfaces. Oxygen management is also vital. The nurse should preoxygenate with 100% oxygen for 30 to 60 seconds before suctioning. Monitor oxygen saturation continuously using pulse oximetry and limit each suction pass to 10 to 15 seconds. Between passes, the client should be reoxygenated for at least 30 seconds. Although coughing during suctioning is expected and aids in secretion mobilization, it should not determine when suction is applied. Relying on coughing as a cue can result in unnecessary hypoxia or airway irritation. Transitioning now to the Stancoast clinical insight. Effective suctioning is a balance of precision and timing, oxygenation before, suction during, withdrawal, and recovery after. The goal is not to remove every secretion, but to maintain airway patency without sacrificing oxygen levels. And now for the Stancoast high-yield NCLEX Pearl. Always insert the catheter without suction to prevent mucosal injury. Occlude the vent only during withdrawal for a maximum of 10 to 15 seconds. Pre-oxygenate before and reoxygenate after suctioning. Maintain suction pressure at 80 to 120 millimeters of mercury for adults, 60 to 100 millimeters of mercury for children, and 40 to 60 millimeters of mercury for infants. Above all, if the client exhibits bradycardia or desaturation, stop suctioning immediately and reoxygenate. Yo, future RN, hold up just for a second.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Gliding into our next high-yield safety checkpoint, let us frame a precise NCLEX-style scenario on tracheostomy suctioning and timing. The nurse prepares to suction a client's airway, aiming to avoid hypoxemia, mucosal trauma, and dysrhythmias. Now, here are the options to consider. Option A, 5 to 7 seconds. Option B, 10 to 12 seconds. Option C, 15 to 20 seconds. And option D, 25 to 30 seconds. Moving from possibilities to precision, the correct answer is option B, 10 to 12 seconds. To begin the rationale, suctioning is an invasive maneuver that briefly interrupts oxygen delivery, so limiting negative pressure to no more than 10 to 12 seconds per pass prevents rapid oxygen depletion, vagal stimulation, and consequent bradycardia or arrhythmias. Furthermore, nurses should pre-oxygenate with 100% oxygen for 30 to 60 seconds before each attempt and allow a full recovery interval between passes to restore saturation. Additionally, applying suction only during withdrawal with gentle catheter rotation enhances secretion removal while minimizing mucosal injury and bleeding. On the other hand, stopping too soon, such as at 5 to 7 seconds, often fails to clear thick secretions, inviting obstruction and atelectasis. By contrast, extending beyond 15 seconds markedly heightens the risks of severe hypoxemia, bradycardia, and even cardiac arrest. As a practical timing cue, some clinicians briefly hold their own breath during the suction pass to mirror the client's safe physiologic window. Finally, continuous pulse oximetry, sterile technique, and age-appropriate suction pressures anchor safety. Adults generally require 80 to 120 millimeters of mercury, children 60 to 100 millimeters of mercury, and infants 40 to 60 millimeters of mercury. Before we lock this in, here is your Stancoast clinical insight. Think of suctioning like a short sprint. Oxygenate first, act efficiently during withdrawal, and pause promptly to reoxygenate, because the real goal is a patent airway, never oxygen deprivation. To wrap this up with a quick memory anchor, the Stancoast high-yield NCLEX Pearl is this. Apply suction only while withdrawing. Keep each pass to 10 to 12 seconds. Pre-oxygenate and reoxygenate every time. Maintain strict sterile technique. And stop immediately if bradycardia or desaturation appears. Gliding smoothly into this scenario, the question asks, as the nurse withdraws a suction catheter from a client's tracheostomy tube, which technique best promotes effective secretion removal while minimizing mucosal trauma and hypoxemia? Now consider the options carefully as we build precision step by step. Option A, remove the catheter slowly. Option B, pinch and pull the catheter. Option C, plunge the catheter up and down. And option D, twist and rotate the catheter. Moving from possibilities to accuracy, the correct answer is option D. Twist and rotate the catheter. Here is the reasoning in an evidence-based flow. Twisting and rotating the catheter during withdrawal distributes suction contact around the full circumference of the tracheal wall, which mobilizes secretions adhered to different surfaces while avoiding concentrated trauma at a single point. Importantly, suction must be applied only while withdrawing, and each pass should be brief, about 10 to 15 seconds, to prevent hypoxemia and vagally mediated bradycardia. Before each attempt, the client should be pre-oxygenated with 100% oxygen for 30 to 60 seconds and then re-oxygenated afterward to restore saturation. Shifting attention to what not to do, option A, remove the catheter slowly, is incorrect because withdrawing too slowly prolongs negative pressure, increasing hypoxia and mucosal irritation. Moving on, option B, pinch and pull the catheter, is also incorrect since pinching and pulling creates abrupt, poorly controlled pressure changes. Suction should always be regulated via the thumb port, not by squeezing tubing. Furthermore, option C, plunging the catheter up and down, is unsafe as it violates sterile technique, traumatizes the epithelium, and destabilizes the negative pressure needed for smooth secretion removal. Transitionally leading into the deeper clinical meaning, here comes the Stancoast clinical insight. Tracheal suctioning is not a race to clear mucus. It is a rhythmic sequence of oxygenate suction recover. The nurse's mastery lies in balancing speed with precision, protecting oxygenation while maintaining airway patency. Finally, moving toward your exam-focused summary, let us conclude with the Stancoast high-yield NCLEX Pearl. Always pre-oxygenate and reoxygenate with vigilant pulse oximetry. Apply suction only on withdrawal with gentle rotation. Keep each pass within 10 to 15 seconds. Maintain proper suction pressures. Adults 80 to 120 millimeters of mercury, children 60 to 100 millimeters of mercury, and infants 40 to 60 millimeters of mercury, and stop immediately if desaturation or bradycardia occurs. Let us now move smoothly into our next high-yield question that focuses on airway management and oxygen monitoring during suctioning. While performing tracheostomy suctioning, the nurse must ensure that the client maintains adequate oxygenation throughout the procedure. The question asks, which assessment provides the most accurate and immediate indication that the client is developing hypoxemia? The available options are as follows. Option A, monitoring the level of consciousness. Option B, assessing skin color and temperature. Option C, watching pulse oximetry levels. Option D, counting the respiratory rate. The correct answer is Option C, watching pulse oximetry levels. Now, let us reason this through carefully. During tracheostomy suctioning, oxygen delivery is temporarily interrupted because the catheter partially blocks the airway, reducing alveolar ventilation. The earliest and most reliable indicator that the client is becoming hypoxemic is a fall in oxygen saturation, which is best detected through continuous pulse oximetry. The pulse oximeter measures the percentage of hemoglobin bound to oxygen in real time, providing immediate feedback about oxygen status. When oxygen saturation falls below 90%, the nurse must promptly stop suctioning, provide 100% oxygen, and reevaluate the client's condition. This tool is non-invasive, continuous, and far more sensitive than physical observation alone. By contrast, changes in level of consciousness, as in Option A, appear only after prolonged oxygen deprivation, when brain perfusion has already declined, making it a late warning sign. Similarly, Option B, skin color and temperature, reflect cyanosis and coolness only when desaturation is already advanced, meaning tissue oxygenation has been compromised. Finally, Option D, counting the respiratory rate, reveals the pattern and effort of breathing but does not measure oxygen content directly. So a normal rate may still exist even when oxygen saturation is dangerously low. Therefore, in nursing practice, continuous pulse oximetry is the gold standard monitoring method during tracheostomy suctioning to ensure that any fall in oxygenation is detected at the earliest possible moment and treated before complications such as arrhythmias, brain hypoxia, or respiratory arrest occur. Transitioning now to the Stancoast clinical insight. Hypoxemia is often silent before it is visible. The pulse oximeter speaks first. Listen to the numbers before the color changes. And now, for the Stancoast high-yield NCLEX Pearl. Always pre-oxygenate with 100% oxygen for 30 to 60 seconds before suctioning. Limit suctioning time to 10 to 15 seconds per pass. Re-oxygenate between each suction attempt. Stop suctioning immediately if oxygen saturation drops below 90% or if the client becomes bradycardic. Continuous pulse oximetry remains the safest and earliest method to detect developing hypoxemia. Let us move into this next essential NCLEX-style question that tests your knowledge of airway management and tracheostomy safety. During tracheostomy care, the nurse prepares to change the tracheostomy ties. Which nursing action ensures the highest level of airway safety and client protection during this procedure? Here are your options to consider carefully. Option A. Cut a sterile gauze square to fit around the client's stoma. Option B. Secure the new ties at the back of the client's neck. Option C. Attach the new ties before removing the old ones. Option D. Replace the inner cannula after changing the ties. The correct answer is Option C. Attach the new ties before removing the old ones. Now let us reason this out thoroughly. When performing tracheostomy care, the nurse's foremost priority is to maintain a secure and patent airway at every moment of the procedure. Attaching the new ties before removing the old ones prevents accidental decannulation, a serious emergency in which the tracheostomy tube becomes dislodged and the client loses their direct airway access. This is especially critical for new tracheostomies that are less than 7 days old, as the stoma tract can close rapidly, making reinsertion extremely difficult or impossible without surgical assistance. By keeping one set of ties secured while placing and adjusting the new set, the nurse ensures that the tube remains stable during coughing, movement, or restlessness. Ideally, the new ties should be adjusted so that one finger fits comfortably between the tie and the client's neck, tight enough to secure, yet loose enough to prevent pressure injury. As we analyze the other options, let us start with option A, cutting a sterile gauze square to fit around the client's stoma. This is incorrect because cutting gauze introduces loose fibers that may enter the airway, increasing the risk of infection or aspiration. The nurse should always use a prefabricated tracheostomy dressing, often called a drain sponge, which is pre-slit to fit safely around the stoma. If a pre-cut dressing is unavailable, the proper approach is to fold sterile gauze instead of cutting it. This method maintains sterility, prevents particle contamination, and effectively absorbs moisture around the tracheostomy site. Moving to option B, securing the new ties at the back of the client's neck. This is also incorrect. Tying the knots at the back of the neck can create pressure points that increase the risk of skin breakdown, pain, and airway obstruction if the client lies on their back. The correct nursing technique is to secure the ties at the side of the neck using a double knot, ensuring that the ends are safely tucked in for easy and quick access during emergencies. Finally, option D, replacing the inner cannula after changing the ties, is not the correct step. The inner cannula should be cleaned, rinsed, dried, and reinserted immediately after cleaning, typically within 5 minutes, to maintain continuous oxygen flow and airway patency. Waiting until after the ties are changed could lead to secretion buildup or airway obstruction, which jeopardizes the client's breathing. Transitionally speaking, here comes your Stan Coast clinical insight. During tracheostomy care, airway security always outweighs sterility. An unsecured airway can end a life faster than an unsterile field can cause an infection. And now for your Stan Coast high-yield NCLEX Pearl. Always apply new ties before removing the old ones to prevent accidental decannulation. Keep suction equipment and an obturator at the bedside for emergency reinsertion. Use only pre-cut tracheostomy dressings, never cut regular gauze. Replace the inner cannula immediately after cleaning to restore airway patency. Ensure the tie fits snugly yet comfortably. One finger should fit between the tie and the neck. Let us now move smoothly into another crucial airway management scenario that highlights both mechanical ventilation and tracheostomy safety. A nurse is caring for a client with a tracheostomy who is currently receiving mechanical ventilation. The provider prescribes the use of a cuffed tracheostomy tube. The question here asks, what is the best nursing rationale for using a cuffed tracheostomy tube in this client? Here are the options to consider carefully. Option A, the cuff prevents skin breakdown. Option B, the cuff prevents aspiration. Option C, the cuff is more comfortable. Option D, the cuff reduces infection. The correct answer is option B. The cuff prevents aspiration. Now, let us explore this in depth. A cuffed tracheostomy tube is specially designed with an inflatable balloon known as the cuff, around the distal end of the tube that sits inside the trachea. The most important rationale for using a cuffed tracheostomy tube is to prevent the aspiration of oral, gastric, or nasopharyngeal secretions into the lower respiratory tract. When the cuff is inflated, it forms a tight seal between the tracheal wall and the outer surface of the tube, preventing fluids and secretions from leaking into the lungs. This function is vital for clients who have impaired swallowing, a decreased level of consciousness, or who are receiving mechanical ventilation. Furthermore, in mechanically ventilated clients, an inflated cuff ensures that positive pressure ventilation is effectively delivered to the lower airways without air leakage around the tube. This maximizes tidal volume delivery, maintains oxygenation, and ensures efficient ventilation. Without a properly inflated cuff, oxygenated air can escape through the upper airway, leading to hypoventilation, hypoxia, or ineffective ventilator cycles. However, it is equally important for nurses to remember that overinflation of the cuff can be dangerous. If the cuff pressure exceeds 25 millimeters of mercury, it may compress tracheal capillaries, resulting in mucosal ischemia, tissue necrosis, or even tracheoesophageal fistula formation. Therefore, cuff pressure must always be checked with a manometer every shift or according to institutional policy, keeping it within the safe range of 20 to 25 millimeters of mercury. On the other hand, uncuffed or deflated tubes are used when clients are being weaned from mechanical ventilation, have an intact swallow reflex, or are at low aspiration risk. During the recovery phase, nurses may perform cuff deflation trials to facilitate speech or swallowing, but this should always be done under supervision. It is also worth clarifying that the cuff does not prevent infection, as bacterial colonization of the tracheostomy site can still occur despite the cuff's presence. Infection prevention relies on meticulous sterile tracheostomy care, proper suctioning technique, and keeping the stoma area clean and dry. Similarly, the cuff does not make the tracheostomy more comfortable. If anything, excessive pressure can increase discomfort or cause coughing. Prevention of skin breakdown relates to external stoma care, not the internal cuff. Before we move forward, let us pause for a vital insight from Stancoast clinical practice. Think of the cuff as the safety valve between the lungs and the upper airway. It guards the lungs from aspiration and air leaks, but demands respect through vigilant pressure monitoring. Now, to reinforce your NCLEX preparation, let us focus on the key takeaways. Stancoast High-Yield NCLEX Pearl. Use cuffed tracheostomy tubes for clients on mechanical ventilation or those at high risk for aspiration. Maintain cuff pressure between 20 and 25 millimeters of mercury to prevent tissue damage. Check cuff pressure every shift or after repositioning or tube manipulation. Deflate the cuff during speech or swallowing exercises when prescribed. Avoid overinflation. Safe airway management is all about balance.